Hey there, welcome back to the show. Today I have my beautiful colleague and mentor, Jill Chmielewski, to talk about estrogen. It gets such a bad rap, but we love it and we need it. Before we dive in, Jill is a registered nurse, women's health expert, and menopause educator who's calling BS on the "it's all downhill from here" narrative on aging and teaching women how to reconnect with their bodies, support themselves through pausal stages, and advocate for their well-being forever and always. Jill believes education is the key to helping women understand their bodies, manage their health, and advocate for themselves as they age. Jill created the Beginner's Guide to Hormone Replacement Therapy to help women navigate the wild ride from perimenopause through menopause and beyond. In 2022, she launched the fabulous Pausing Together, an online community for women to connect, learn, and open up discussions on topics that affect pausal women. Jill is also a medical advisory board member at the Institute of Bioidentical Medicine, whose mission is to improve the standard of care in menopause medicine. Jill is a frequent guest speaker and has been called upon as a pausal guest expert on many podcasts. So I am thrilled to have her here on Perimenopause Simplified today. Welcome, Jill.
Oh, thank you. Thanks for having me. I'm excited for us. We've known each other for so long,
Yeah.
but we've never done an official, I think, like a podcast like this. This is really fun.
Yeah.
Yeah.
I'm excited because we're gonna dive into estrogen today.
Yes. Yes.
The role that it plays in perimenopausal symptoms, the misconceptions, as well as the benefits of estrogen hormone replacement therapy. So I'm excited to have this conversation.
Yeah, me too. Me too.
Yeah.
Yeah.
So can you tell us, why is estrogen so important to us?
Yeah, it's so funny. I feel like I feel like there's so much noise in the menopause space. And if we just go back to the body itself and say, okay, what does estrogen do in the body? We've learned that there are estrogen receptors in the body, and these estrogen receptors are receptors, for people that don't know, cells have receptors on them. They're sort of like little satellite dishes that sort of catch these hormones, will travel through the blood and signal a receptor. And we didn't even discover the receptors. And, this has been like, I don't know, several decades that we've actually discovered these receptors. And I think most of us think about estrogen or hormones in general, especially the quote unquote sex hormones, as being just important for reproduction. So periods and pregnancy. But what we've come to find out is that these hormone receptors are on all of the cells throughout our body. So it tells us, okay, if we have estrogen receptors in our brain, our bones, our blood vessels, our vaginas, our vulvas, our urinary tract, our skin, digestive tract, heart, what am I leaving out? Liver, kidneys. I mean, you name it. And there are hormone receptors everywhere, estrogen receptors. So, I mean, our eyes, ears, I mean, we're even learning about vocal cords and things that we didn't know before. It sort of tells us, okay, well, whatever there is a hormone receptor tells us that it's needed for a signal to communicate to that cell and tell that cell a set of instructions, something to do. So, if we have an estrogen receptors on every cell throughout our body, that's pretty apparent that estrogen is really important in the body. Our
Right.
body really values estrogen. Yeah.
I would
Yeah.
say so.
Yeah. So it sort
Yeah.
of does all of these things. That's the thing. It's like
Mhm.
signaling all of the receptors. So it's like when you think about kind of head to toe, north to south, it's like in the brain, it's helping, again, memory. It's best friends with neurotransmitters. So it's going to help sort of with our mood, with sleep, with temperature regulation. And we kind of go down. Our skin is plump and moist and elastic because of estrogen. And again, there's all these factors sort of working with estrogen. But you go through the body and it's like every single function in our body is relying on estrogen for something. And
Mhm.
so when people say, we hit perimenopause and menopause and hormones change, and they're like, well, those were our sex hormones, sort of like, oh, well, it's like,
Mhm.
well, we still have these receptors all throughout the body. So,
Mhm.
I think you and I have a very different opinion about estrogen after menopause, during perimenopause and after.
Yes, for
Yeah.
sure.
Yeah.
I've shared my own perimenopausal journey, if you will,
Yeah.
here, and how I had very low estrogen, also because of my health history of my prolactinoma, which tends to lower estrogen. And I felt those symptoms very
Yeah.
loudly.
Yeah.
So when a lot of women complain about symptoms that they're dealing with, oftentimes they're not even attributing that to hormones, but certainly not estrogen. So
Yes.
can you speak to some of the symptoms that women start to experience in perimenopause and even menopause,
Yeah.
when it comes to this fluctuating estrogen that's happening and then
Mhm.
low estrogen.
Yeah, so I think I know you've talked about it before because you just had Carol on too with progesterone, and we talk about progesterone, but progesterone's typically that first hormone to decline, and then estrogen sort of goes on this wild roller coaster ride. So, do you want to just hit estrogen, or do you want to talk about progesterone too? Mostly
We can talk
estrogen?
about both, but
Yeah.
yeah,
Yeah, I
certainly.
mean, so progesterone, I always think of it's like this is like in our mid 30s. I mean,
Yeah.
could be earlier, could be later, but in general, our hormones peak in our 20s. And so in our mid 30s and late 30s, and it could be early 40s, depending on the woman, progesterone kind of goes on this downward descent. And it's sleep is one of the first things we see change. Anxiety we see kind of starts to increase. Mood changes. We see weight changes. We see just like a general calmness with progesterone, because estrogen has more of these sort of stimulatory signals, especially on the endometrial lining. We'll see when progesterone declines that women will have heavier periods, maybe more problematic periods, maybe more PMS. So that's kind of a lot of those sort of initial changes that we'll see in perimenopause. And then estrogen goes up and down before it starts to go down on its descent. It's on this feedback loop with our brain. So our brain talks to our ovaries, and there's sort of this constant looping feedback loop saying, okay, estrogen is declining. We need to make more estrogen. Estrogen is declining. We'll make more estrogen. So our body really wants to have these very level amounts of estrogen in the body. During perimenopause, though, it's a little bit of like a spotty Wi-Fi signal. So sometimes it's really high, sometimes
Hmm.
it's low. And so we can have symptoms of both low and high progesterone or estrogen. So women get a little confused because they're like, okay, I had a really heavy period, which would make me think I have enough estrogen, but I had like I have really bad depression. And that's definitely more of a low estrogen kind of symptom.
Hmm.
Big ones that we see, and I think the ones like the hot flashes, we know we hear about those all the time.
Hmm.
Weight changes, issues with like insulin resistance and things like that. We certainly see more blood sugar challenges. But other things that I feel like we don't talk about a lot are those musculoskeletal system changes,
Hmm.
huge and very much tied to estrogen
Yeah.
because there's so many receptors in the bones and the muscles and the ligaments and the tendons and the connective tissue. And so frozen shoulder and plantar fasciitis and these like aches and pains,
Hmm.
where women just are like out of nowhere, they're like, oh my gosh, everything kind of hurts or
Yeah.
can't lift my arm up anymore. So, and that's that kind of up, down, up, down. So it can be kind of confusing for women. Oral health changes we see a lot because there's so much
Hmm.
blood flow to the mouth and there's lots of estrogen receptors. So women will have, their first like funky dentist appointment where they feel like they
Yep.
sort of failed the dentist appointment.
Right.
Menopausal rage. I mean, this list is
Yes.
again, because we're going throughout the body, the symptoms are all over the place, but we can see breast tenderness,
Hmm.
shorter periods, longer periods, I mean, kind of everything in between. So it can be a time of really, really erraticness for women, really, really difficult for women at times.
Yes.
Yeah.
I try to bring lightness to it, but it really can be so challenging.
Yeah.
And depends on the woman. Some women's symptoms are more severe than others.
Yeah.
And I think it's important that we do bring to light some of these symptoms that, again, they don't often realize are tied to their hormones.
100%.
You were talking a bit about like heavy periods, and the idea that estrogen fluctuates a lot in this stage of life. And
Hmm.
I want women to really understand this because, especially in the social media space, there's a lot of noise,
Yes.
and a lot of people will talk about estrogen dominance. So,
Yes.
can you speak to that because it is a little different in perimenopause versus maybe a woman in her 20s or early 30s?
Yeah. I mean, in period, it's interesting because you can have estrogen dominance if you have high estrogen, medium estrogen, or low estrogen. It's really in relation to progesterone. And so, so women, because again, that feedback loop, our brain, our body wants estrogen. So it will send some strong signals to our ovaries to try to produce estrogen. At times, we can have very, very, very high levels of estrogen. And in fact, if we did a blood test at that time, at that moment, and this happens all the time where women get that
Mhm.
blood test and they're like, I'm not in perimenopause. My estrogen's super high. Well, that's because that was that moment when estrogen was really high, but it could be followed by a low.
Mm.
And so we'll see that kind of erraticness happening. Let's just say you have high estrogen or it's going up, down, up, down. You probably over the course of like the cycle, probably have a fair amount of stimulatory signals on that endometrial lining, that estrogen dominant symptoms. I guess that's the big symptom people are thinking about because you have those heavier periods and heavier bleeds and things like that. So you are estrogen dominant because you're not making as much progesterone. If you have kind of middle estrogen, let's just say it's kind of somewhere in the middle, but progesterone is lower, you're still estrogen dominant. It's not, and of course, we also have estrogen mimicking chemicals on our planet that are
Mhm.
everywhere. So I feel like in peri, especially, I feel like we really see that stuff heat up. So we've got these ovarian changes where estrogen can be, relative to progesterone higher, quote unquote, estrogen dominance. But if we brought that progesterone up, we'd have less estrogen dominance. We can
Right.
start bringing progesterone up sooner before we bring estrogen in, try to level that off a little bit.
Mhm.
Women can have low estrogen, so really low, where they're having very significant low estrogen symptoms. They're in their final stages, just about to hit menopause, really, really light periods, because again, no, not that much stimulation on the endometrial lining. They're having
Mhm.
maybe genitourinary syndrome of menopause, or at least some symptoms of vaginal changes, maybe feeling a little more pain with sex, maybe a little discomfort, maybe more dryness, maybe dryness all over.
Mhm.
But if progesterone is lower, you still have estrogen dominance. So
Right.
it's such a funny word. I guess there's not
Yeah.
really a better word, but it's
Yeah.
sort of understanding the nuance, right? With everything in this space, it's all about
Yes.
nuance. Yeah.
Yes.
Yeah.
Yeah. And because I think the term often puts estrogen in a bad light.
Yes.
Like we have to detox it. We have to get rid of
Yes.
estrogen. And I'm like, please don't. We love
No.
estrogen. We need it.
Yes. Hold on
It
to
is
it as
not
long as you
fun without
can.
it.
Yes. It is
Yeah.
so true, Claudia. It's so
Yeah.
true. Yeah.
Yeah. So on that topic, why is there so much fear around estrogen, do you think?
Yeah, I mean, I think we're still stuck in the days of the WHI, the Women's Health Initiative, which was, we really just started studying women in the 1990s. Women don't even realize that we were never part of research. So we've been studying for about 30 years. That's it.
Wow.
And in the 1990s, the Women's Health Initiative, which was like the largest ever study done on women, looking at hormones. At the time, just so that women know, they used synthetic hormones. So they're not even the same hormones that are in our body. They're very different, actually quite different. Different formulation, an oral formulation of either estrogen, a synthetic estrogen made from the urine of a pregnant horse, or and that was in pill form, or a synthetic combo pill, which was that same synthetic estrogen with a synthetic progestin, not the same as
Hmm.
progesterone. So those were the two formulations used. And essentially what happened is early on, the study was prematurely stopped because of sort of a handful of the WHI researchers said, hey, we think in this one arm of the study, we did this preliminary kind of combing of the research, perusing the research, and said, hey, we think there might be a slight increased risk of breast cancer in this one arm of the study, which was the women taking the combo pill of synthetic estrogen and synthetic progestin. It was not agreed upon in the group that there was an issue, and even the researchers that said it said even when looking at it, it's statistically insignificant, which means in the medical world we would never make a medical decision on that. But it was a very funky sort of unveiling of this message. And what happened is these researchers went to the media. They said estrogen, they basically said, estrogen causes or HRT causes breast cancer because they saw that initial pass. And that's what the media picked up and just kind of ran with it. And even early on, I mean, the other researchers kind of came together, looked at the data. They knew very early on that that was not the case. That actually it was untrue. And so many of the researchers and other people that were still prescribing were going through the data and really realized actually in the women that were receiving estrogen, there was less risk for breast cancer, a significant amount less risk for breast cancer. And in women who had gotten breast cancer while on estrogen, they had less risk of dying from breast cancer. But it took 18 years for the WHI study committee essentially to republish, retract that information, publish the retractions of what they had said.
Yeah.
They didn't say, oops, it wasn't true, but essentially what they said is actually it wasn't true. And actually, women who are on hormones have less risk of developing breast cancer. And that's out there. And we have research showing that. And still, you ask women about hormones, and they're like, no, it causes breast cancer. And it's one of those situations where it's like, It never should have been said because it was never true to begin with.
Yeah.
But we just can't detach ourselves from it for some reason because it was said and it was so loudly said at the time.
Hmm.
I wish media had picked up the news story in 2018.
Yeah.
And it wasn't even a news story. It really was well known before that, but it finally took the WHI, I guess, that long to really get that information out and actually officially retract the statement. So I think it's been demonized ever
Yeah.
since, wrongfully so.
Yeah.
Yeah.
Well, and it's still demonized in regards to breast cancer. Can we talk a little bit about that?
Yeah. Yeah. So I think because you hear the term ER positive breast cancer, women say, okay, estrogen driven. And I think, we can thank Avram Blooming, Dr. Avram Blooming and Carol Tavris for their amazing work. So for those that don't know, Dr. Blooming is a medical oncologist who treated women with breast cancer. Carol Tavris is his writing partner, and they wrote a book in 2018, right around the time that this came out from the WHI, essentially debunking that myth as well, saying estrogen does not cause cancer. Estrogen does not cause cancer. And so Dr. Blooming and Dr. Tavris, who's a PhD, also say in the book and really explain this at length, just showing that ER positive, estrogen, ER is estrogen receptor. So ER positive means estrogen receptor positive. PR positive means progesterone receptor positive. Breast cancer, we expect normal healthy breast cells have estrogen and progesterone receptors in them. We would expect that. And
Mhm.
so, when we biopsy a tumor, when it's biopsied and you look at that tumor and say, what is it? If they see estrogen receptors in it, it's considered ER positive. Doesn't mean that estrogen caused the tumor, just means they see estrogen receptors in that tumor sample, in that pathology. But it's not the cause of the breast cancer. And so that's where it gets really hard because then, of course, for a lot of the treatments, it's like, okay, we have to stop your estrogen quickly, turn off the estrogen. And we have a lot of debate about that still, about how that, is that really the right thing to do? Because according to Dr. Blooming and Dr. Tavris, it's the cancer stem cells that are really sort of responsible for cancer and for metastatic cancer or cancer that shows up again or recurrence. And
Mhm.
those do not have receptors for estrogen or progesterone. So
Wow.
we're still in that state of, I think we can't let go. And I think
Mhm.
because we see estrogen as this like proliferative, a growth hormone or stimulatory hormone, it
Mhm.
must mean that it stimulates breast cells like over and beyond. But really, that's an internal check and balance system in that woman's body that just did not shut off, that should have shut off, that had nothing to do with estrogen. That's just its own animal. And we got, again, even Dr. Blooming will say, we still don't understand breast cancer. I mean, we want to
Yeah.
say we do. We still don't fully understand it. So,
Mhm.
but the research and especially his very first chapter is does estrogen cause breast cancer? And I think I tell all women, every woman I can who will take a minute to listen, I'm like, get that book, read
Yeah.
chapter 1. If you read nothing else, just read
Yeah.
it because you kind of go, oh, you realize how we've been sort of sold this idea that is just simply doesn't make any sense and is just not true.
A lot of women, in my opinion, and I know yours, would
Yeah.
benefit from hormone therapy,
Yeah.
replacing estrogen. So, when is a good time to start that typically for women? When is it too late? Is it ever too late?
Yeah. Yeah.
Yeah, let's just talk about that and the benefits of considering replacing
Yeah.
it.
Yeah, I mean, I feel like going on, I mean, we always say testing, I don't want to diss those that test because I feel like if you want to test. I know for a lot of people they want that data point. What we always say is it's not that reliable. It's not reliable. So because those levels are fluctuating, especially in perimenopause, it's like you've got perimenopause where levels are going up, down, up, down. And then you've got menopause where we know that your levels are low because you're in menopause. You don't have enough hormone to actually build a uterine lining. So we know for sure that you have low hormones. So it's sort of like,
Mhm.
what's the reason to do the test? Now, if someone
Right.
says, I absolutely want to do it, you can do it. But just understand that if we catch you on a high day, it's going to be really high. If we catch you, or
Mhm.
a high moment, it could be 3 PM, it was high, but maybe at 2, it was low. So you just have to understand that it's going up, down, up, down. That's why we usually say go off of symptoms. So when women start
Mhm.
to report symptoms, generally it's going to be those low progesterone symptoms first. But it might not be, especially because I think, a lot of the medical community now wants to change, is really kind of pushing. You'll see more and more in the research where they're pushing, like, we don't want to call it HRT. They wanted to call it
Mhm.
HT, which is hormone therapy. Now they
Yes.
want to call it MHT, menopause hormone
Mhm.
therapy. And I feel like there are times in women's lives throughout their lifespans where they may benefit from hormones. So I sort of prefer the HT, like hormone
Yeah,
therapy or HRT, because there are
me too.
times, you could be in your 20s and need it because of
Yes.
something. You might
Mhm.
need it postpartum.
Yes.
We have environmental toxins everywhere, a lot competing. So I guess hormone therapy in general is not just for the perimenopausal or menopausal woman. That's kind of the first thing. So we go off of symptoms, we look for symptoms. And if we see either those sort of high or low symptoms, we can replace. Now, a lot of physicians have gotten pushback from that. And I can just say what I've learned on that, because what I've heard from a lot of physicians is they'll say, well, or women will say, my doctor said I can't replace it till estrogen is low. But that whole feedback loop, I always kind of equate it to like a thermostat. So,
Mhm.
if you set the thermostat for, let's say, like 72, all of a sudden it drops. Let's just say it's hot or it's cold outside. And all of a sudden it drops to like 68 in the house. All of a sudden you'll feel this big surge of heat come on. And now you're about, the thermostat is really, the heater's working to really get that level up, to get that heat up. So you're meeting 72. That's kind of how I think about the brain ovary connection. It's like, the
Mhm.
brain is sensing that the ovarian production of estrogen is going down. And in response, it's like, oh my gosh, kick out more. So it's like
Yeah.
yelling at the ovaries. It'll kick out a lot more, but then it'll drop again because it cannot maintain and sustain those levels. So bringing, estrogen in when someone's even going up, down, can level that off. It kind of calms the brain. The brain's like, oh, we don't need to have these massive surges because we've got a little bit of hormone in the body. And so, we tend to find, and a lot of the colleagues who I am, at the Institute of Bioidentical Medicine with, we're always doing grand rounds every week. We are talking about patient cases, and just also other colleagues will bring estrogen in to level off the estrogen so it's not going up down. So you absolutely can bring it in before it started on its downward decline. And then, of course,
Mhm.
when it's going down, that's another great time to bring it in if you haven't already.
Yeah.
The benefits of doing it earlier, I would say, I think about HRT in two ways. One is, or for two sort of purposes. One is we have those acute symptoms that are life disrupting for some.
Mhm.
Some it's very mild. But it depends on the woman. But either way, if you are not sleeping every night, if you're having hot flashes every night, if there are things that are constantly getting in the way of you being your best self,
Mhm.
that's a great time to bring hormone therapy in because you're going to feel better. And when you sleep, you can heal and you can clean up the body, the day's work of your body. And, that's when all of the magic happens. And a lot of women just keep going, for months, almost years without sleep, without
Mhm.
hormones. So that's where I feel like those acute symptoms that can be so helpful. But I think the bigger picture is really those silent physiologic changes that happen. So, as our hormones are changing and they're declining, and this is happening in perimenopause, not menopause, we go back to perimenopause, we're starting to see those downward declines. We will start to have more vulnerability to bone loss and blood vessel changes and brain changes and vaginal changes and skin changes and digestive tract changes and all of these things. So it's the silent things that oftentimes we don't feel it happening, but it's happening. And so we know from the research that the earlier the better. Rather than waiting for those changes to happen, we're going to have much more benefit if we start it early. So if we can get those on board in perimenopause, even better. If it's actual menopause, let's say 12 months after your last period, okay, if it's not and it's within a period of time after that, it's just the earlier the better because we can continue to have those protections in the body. It's never too late. I always tell women it's never too late. Do the benefits outweigh the risks for you? I mean, and in our camp, we always say hormones are just such an important molecule in the body that benefits, almost always outweigh risks. I mean, we have had hormones in our body since we were in puberty, these hormones,
Mhm.
and we were walking and rolling and all was well. And all of a sudden women are told they're not candidates for the
Yeah.
very hormones their body's been making since puberty. And HRT is tiny, tiny, minute amounts of
Right.
hormone versus what we had when we were in our 20s or 30s. So I feel like all women are candidates. There may be times where it's better than others. There may be
Mhm.
doses or forms that are better, but anytime it's just being realistic about your expectations. If you still have hot flashes and sleep issues at 62 and you went through perimenopause or menopause at 51, probably going to find some pretty good benefits with those
Yeah.
hormones. If you have significant cardiovascular changes, can hormones bring those blood vessels back? Probably not. Can there be some
Mhm.
benefits? Yeah, potentially there can be, but we don't know the extent again because the research really hasn't been done and it's so hard
Mhm.
with dosing and timing and all these things. But Bone health, we know that even in older women, they can really experience benefits with estrogen and progesterone if they have osteoporosis and osteopenia,
Mhm.
vaginal symptoms, urinary tract symptoms, cognitive issues, things like that. There's so many benefits. So I feel like, again, we always say benefits versus risk in your body, but just that women understand that they have had these exact hormones in their body since puberty. So that's where it's like we're just essentially, making sure you have some on board so that they can signal those receptors in the body. Long answer, I know, but hopefully
Oh,
that's,
it's
yeah.
perfect. I love
Okay.
it. Because we need this information because there
Yeah.
is so much misinformation and
Yeah.
there's a lot of fear and confusion and conflicting advice out
Yes.
there. But just everything you're saying about like these are hormones that we've always had. And a lot of women will say things like, well, I want to do things naturally in my old age, or they're afraid of replacing hormones. And I think to myself, but you were on like hormonal birth control for
Yeah.
15, 20 years.
Yeah.
Can you explain the difference between the two?
Yeah. Yeah. I hear that all the time too. I hear the natural thing too a lot. And maybe we
Hmm.
can table that and
Yeah.
talk about that one next because that's a really interesting one to dive into. So the birth control pill is synthetic. Again, this
Mhm.
is synthetic. These are not the same hormones that are in your body. The estrogen is a high dose. It's a high enough dose that it's going to stop you from ovulating. So you have a synthetic estrogen. It's oral, so it's taken by mouth, which we know increases clotting risk. And for women who say, well, no big deal, it's a big deal. There are women who have had strokes in their 20s because
Mhm.
of the birth control pill. Now, everything again, benefits versus risk, but just kind of to understand, we sort of, like you said, Claudia, like I think they say 80% of women have been on the pill at one time. I was on
Yep.
it. I
I
was
was.
never told benefits and
Nope.
risks.
No.
But the benefits risk discussion is important with the birth control pill. But essentially, you have this high level of estrogen, and even on the low dose pill, it's got to be high enough to disrupt ovulation. So, even the low dose is still high enough to disrupt ovulation. The progestin in it is not the same as the progesterone in our bodies. We make no progesterone then essentially when we're on the birth control pill. So all we have is a progestin, which has sort of the opposite effects that progesterone has in our body, except for, controlling the growth of our uterine lining. That's really the only thing they share. And then it can dial down testosterone because it increases, this protein sex hormone binding globulin, which will kind of lock up our body's production of testosterone.
Yep.
So it's sort of like you're flatlining women's hormones. You're giving them a lot of
Mhm.
estrogen, but you're flatlining the rest of their hormones, probably interrupting some of their own estrogen production as well. Versus HRT, like bioidentical, body identical hormones, which are the same hormones that are made in your body. Now, they are made in a lab, so people will argue, well, they're not natural. Well, like anything, they are synthetic in the sense that they do have to be made in a lab, but
Mhm.
they are made into the same hormone that is made in your body. So it's bioidentical. Your body doesn't know the difference between the estrogen you're taking, that's HRT body identical versus the hormone that's made in your body. It signals the same receptors. It communicates in the same way to those receptors. We don't know exactly what the birth control pill does. We do know that the progestins are more stimulatory to breast cells. We're seeing more and more with that. We know that there are a lot of other side effects, bone issues, because again, you don't have this estrogen and progesterone working together to build bone and remove old brittle bones. So it's sort of a flatlining. I would say it's almost like you're in a little bit of a mini menopause to some
Yep.
extent because we're kind of flatlining hormones with the birth control pill, where bioidentical hormones are body identical and they're much, much lower doses. These are like minute doses. So
Mhm.
not enough to bring a period on. So if that kind of tells you anything, they're really low doses. Yeah.
Wow.
Um, but the natural, maybe we want to talk about that
Yes, I would
because
love to talk about that because and sometimes I think people think that they look at me, they're like, wait, you're talking about hormone replacement therapy, but you're a health coach. You should do everything holistically,
yes,
everything naturally. And what supplements can I take? And I'm like, I
I
just
know.
want to scream because I mean, yes, of course, changes to your food is important, your lifestyle, stress management, addressing underlying nutritional imbalances, looking at your gut health. Yes, we're team supplements when needed and
Yes.
all of that. But our hormones, in my opinion, are incredibly natural, more so than the adaptogens that are flooding
Yes.
Instagram, right? So can you go
Yes.
ahead, speak on that? Because I know you feel the same.
I know. I don't, it's so funny. It's like I think it's right, like what's considered natural. It's kind of like I always say, like they were like, it's a crutch that we're using, right? But it's not a crutch. I mean, we have other hormones too that we replace when we no longer make them. If we no longer
Mhm.
make thyroid hormone, we take a thyroid hormone. If we no longer make insulin or make lower amounts of it, we take insulin, and we don't seem to bat an eyelash at those. When you say estrogen, progesterone, testosterone, immediately it's unnatural. Why would we
Right.
do that? I don't think women understand that, the average life expectancy for women in the United States, and this is like in 1900, was 48.
Wow.
So now we're living, and the reason we're living now, that doesn't mean some women, of course, lived longer, but the average was 48. The average now is like 78 point whatever, 79. Let's just say we could say 80 just to round up. So you're talking about 50 more years. We are living 50 years longer in a pretty short period of time, 124 years. We've now extended life expectancy by another 30 years for the average woman,
Mhm.
because of artificial things that we have, because we have antibiotics and we have surgery and we have treatments, and we can do anything to keep people going and keep people alive no matter what. We have better sanitation, we have
Mhm.
food, we have, supplements that with, like different nutrients and things like that that we can supplement for people. So we have artificially sort of extended our lives beyond 48. And I
Yeah.
think we're all grateful for it. But there is a cost to not having these very, very important life hormones, not just reproductive, but like whole body hormones in our
Mhm.
body. We know for a fact that cardiovascular changes happen in tandem with this, right? We know that bone loss happens in tandem. Like we know cognitive changes happen. We know genitourinary system changes happen. So we know all these things happen as a result of hormonal decline. So we
Mhm.
can either let those things happen or and later end up on this. What happens for most women, a large portion of women, is this polypharmacy where you're on, my mother-in-law's on 14 medications, bisphosphonate drugs,
Yep.
statins, high blood pressure meds. I mean, the list will go on and on and on because we didn't do these things. Now, yes, the lifestyle stuff is so important, but there's no lifestyle practice on the planet that can jumpstart our ovaries to make hormones again. So
Yeah.
and we can take supplements and we can
Mhm.
do things to kind of as workarounds. And some of those supplements and adaptogens will signal those receptors. It's a much weaker signal, so it's not going to give that same impact. And so I think it's more about natural to me, the supplement, the ashwagandha, the herb, and I love them all, love them all. They're not actually made in the body, but hormones are
Right.
made in the body. So they're like the
Mhm.
most natural thing we can do is replace like with like, exact same molecule with the exact same molecule, instead of trying to find some workaround, because we know that this is how these hormones work in our body.
Mhm.
There's so many other things that we don't have a problem with supporting. We know in our 40s and 50s, right? All of a sudden we can't read anything close to us. We go and we get some readers. I
Yeah.
mean, otherwise we're going to go through life not being able to read. Like it's
Right.
okay to do things to help support our body. We have the hormone signals. So why not, to me, the most natural thing, the thing that we know how we're going to respond to because we've had these hormones in our body since puberty, is
Mhm.
hormones. Again,
Yep.
we have a process for onboarding women with hormones so that we're doing it the
Mhm.
right way and, bringing them on right, and using the right form for them and everything. But I mean, in truth, it's like women, most women, who do we know? I mean, it's very rare we find a woman in her 70s even that has, even women who say, well, I feel pretty good. But when you dig into it, they're like, well, I do have osteoporosis and I'm on a
Yeah.
statin and I'm on a high blood pressure med. So if we
Mhm.
want to avoid that, it's just a personal decision on, this is what we see to be the most protective in the body as we age.
Yes. And it absolutely is a personal decision. However, I would venture to say that most people want to be able to walk when they're older.
Yes.
They want to be able to pick up their grandkids. They want to be able to travel, pull their suitcase through the airport, right? And
Yeah.
not worry about falling and potentially fracturing something that could potentially lead to death.
Yes. And it
So,
does
and it
oftentimes.
does.
Yeah.
And even just the cognitive decline. I mean,
Yeah.
sometimes we joke around about it, like, oh, I can't remember things, or I walked into a room and I don't know why I'm in here. And it's like we laugh about it, but it's like, yeah, this is happening now in your 40s. So if you
Yeah.
don't do something about it now, it's not going to get better.
Right.
So we have solutions.
Yes.
It's just a matter of finding the right practitioner who's going to obviously prescribe and know do their due diligence. But sometimes it drives me bananas when I'll hear somebody say like, oh, well, so and so lived until their 80s or 90s, or people in this country, and I'm like, yeah, but what is their quality of life?
Yeah. Yeah.
Because let's dig into that. So many people think just living is health. And I
Yeah.
think to myself, no, well, I want to live healthfully. I
Yes.
want to have my memory. I want to be able to have a conversation. I want to be able to walk. I want to enjoy my life in
Yeah.
my 70s and 80s, hopefully if I live that long.
Yes.
So,
Right. Right.
to me it's like we've settled for mediocrity when it comes to health in this country.
I totally agree. It's like, and health span does not match lifespan. I think they say the average health span for women is like 62 or
Right.
63. So if we're going to live to 78, 79, 80, I mean, and many women live longer,
Mhm.
we're talking about 15, 17 years of our health span not matching our lifespan. So we're from 62 onward going to doctor's offices, taking a lot of medications. And it doesn't, we just, again, we had to just go back to the physiology of the body. How does the body work? We know these hormones are so important in the body. That's why I don't know why there's so much pushback and argument about something that we don't argue about insulin. We don't argue about thyroid hormone. But for some reason, estrogen, I don't know if it's just because they've been seen as like quote unquote sex
Yeah.
hormones. It's like we have to kind of detach ourselves from that and understand that they are signaling receptors throughout the body. And I often wonder too, if there's not signaling in the receptors, if we don't have hormones on board and we've got this planet that's filled with hormone
Mhm.
disrupting chemicals, is it the chemicals that are going to nestle into those receptors and signal those receptors? So
Mhm.
again, we want some competition there, right? To try
Yeah.
to there's those
Right.
those chemicals out as it is, but it's just to me it's like a logical common sense kind of thing versus something that, and I think women will say, well, I want more research, I want more studies, I want randomized placebo clinic, controlled clinical trials. We're not going to have them because we cannot possibly gather all this information and follow women for, by the time we follow all these women for decades and decades, we're not going to be here. So
Yeah.
we have to just extract and pull from what we know about what hormones do in the body.
Mhm.
Not to say we shouldn't study them, but I think, there's a lot of people like, well, I want more, especially when it comes to testosterone. We need more information. We
Mhm.
know what testosterone does in the
Yeah.
body. We know what it does. So do we need more information? Can we just like see how women do clinically when they come to us and say, I feel terrible, or I
Mhm.
have all these symptoms, they start hormones, and a week later, a lot of times, they're sleeping, their
Yeah.
libido's up, everything has changed. My frozen shoulder is gone.
Mhm.
That should be enough evidence for us,
Yeah.
rather than saying we have to have these like exhaustive clinical trials that will never happen.
Right.
So, it's a really tough, yeah, it's a really, it's very noisy out there right now in the
Oh,
menopause
so
space.
noisy, so
Yeah.
noisy. I mean,
Yeah.
we have clients who come to us and they'll say like, "Oh, this doctor said this," or "What about this
Yeah.
person on Instagram?" They'll send us stuff, and I'm like, "Oh my gosh, just please like cut out some of the noise." And
Yeah.
not that, and I always say to them, "Listen, I think it's wonderful that you're educating yourself and you're asking these questions and you're doing this research, but I also know that a normal woman, this isn't her expertise. She's not really digging into the research. It can be so overwhelming. So I say
Yeah.
just stick with people who you trust and yes, ask questions, advocate for yourself. And it's hard because sometimes they don't even know who to trust.
Yeah.
And especially when they go to their doctor in regards to, hormone replacement therapy, obviously we're both fans of it. We both use it
Yeah.
ourselves.
Yeah.
In addition to all the food and lifestyle changes, we both have health coaching in our background. So we're all
Mhm.
about holistic living, but we also love replacing our hormones. So why is it so hard? Well, we know why it's so hard for women to find a doctor. I mean, at least in regards to what I've shared in the past, that a lot of doctors are just not getting the education. They
Yeah.
don't know what they don't know. So how can women find practitioners who are going to better guide them and prescribe HRT?
Yeah, I mean, I feel like for women to get the education, I mean, the earlier the better. If you can start in your 30s and think about like what's coming, because it's going to hit every woman goes through it. And it
Mhm.
sounds doom and gloom. It's not doom and gloom. It can be awesome, but you do have to prepare for it, just like any other stage, right? So the earlier the better. If you can start kind of, I almost just say it's like you have to kind of just do your detective work. If you had, if you were going to see an orthopedic surgeon or a specialist of any kind, you would kind of see what they're all about. You'd want to kind of understand what they're about, read their background, if they have a website, if they're on Instagram, if they're somewhere, if they publish papers, whatever it is, wherever you can find some information about them. I would say it's going to probably take a few different ones
Yeah.
because they are so hard to find. Again, like you said, there are not as many menopause specialists out there. There are people who claim to be menopause specialists who have taken a course on the weekend and now they're a menopause specialist. But I would say if the bulk of their practice is treating menopausal women, then they're probably a menopause specialist. If this is a
Mhm.
tiny sliver of what they do, it doesn't mean they might not be good at it, but menopause medicine is its own specialty, and it can be hard to get good at anything unless you do it day in and day out, or having the conversations day in and out, and you're kind of
Yep.
dealing with this population of women. So I always say, if you're trying to find somebody, referrals are great. It's not going to be your OBGYN most of the time. It's unless they've gone on for training specifically in this. They are not a hormone expert as much as women want to hear that they are. They're just not.
No.
Sometimes I get some of them are very, very like just great about saying, I'm not a hormone expert. And some get really mad when you say that.
Mm.
But that is not their training. Gynae surgery, labor and delivery, prenatal care, gynecological issues is really what they were trained in, not hormones. Even
Mm.
endocrinologists were not really trained in the sex hormones. So
Nope.
we're sort of it's really tough because we don't have enough providers probably for the number of women out there.
No.
But they're coming and we're seeing more and more. So I think
Mhm.
referrals, I think poking around, doing some detective work, having conversations with their front desk staff, asking them what kinds of hormones they use,
Mhm.
what their sort of philosophy is on hormone replacement. Compounding pharmacies, I think, are just a great resource because they are mixing up and making customized hormones every day. A lot of them, it's like 50% of their prescriptions are hormones. So
Yeah.
oftentimes, if there's a local compounding pharmacist or pharmacy in your area, calling them, they may know who in your state or who in your area does hormones. But that's probably the $1 million question. I wish, even when we recommend like telehealth groups that we know of and other practices, if they get, depending on who they get at that practice,
Mhm.
it's just like anything. I mean, I'm a nurse. So, if someone got me on one shift, I felt like I was a really good nurse and I was really attentive. I knew a
Mhm.
lot of nurses that were not great and they
Yep.
weren't that attentive. And we
Right.
see that, right? Even at great hospitals. So, same
Mhm.
thing with practices, just knowing that you really have to kind of do your due diligence on these providers, see where they were trained, see what their MO is all about. But it's a lot of it, I think, if you as a woman can at least understand kind of the basics, you are going to feel much more empowered to actually like advocate for what you want because you're like, okay, now I know my body enough. I know what's going to happen. I
Mhm.
kind of know, and I know what I want. I know what my goals are. And so you at least can step into your own power, and you should, because
Yes.
it's your body and you live in it. So you're the only one that's going to be able to advocate for yourself. So the more you
Mhm.
know, I feel like the more you can actually, really, really feel good about going out and confident when you go to see a provider. It's so important.
Yeah, I agree. I don't advise walking into something totally blindly.
No.
Like you want to have some information under your belt.
Yeah.
We do educate our clients on HRT. Obviously, I cannot prescribe, my team practitioner cannot prescribe, but we give education and we even give like an HRT cheat sheet because we
Yeah.
want them to be confident. Because I think that's a big part of it. A lot of women will go into a doctor's office, they don't know what to ask. They
Hmm.
oftentimes are frozen in fear because they really look up to their providers. They have a sense of authority, and they've been dismissed, a lot of them, by
Hmm.
doctors, and they've been made to feel foolish for talking about their symptoms or even bringing up the term perimenopause. They're often told, "Ah, you're too young for that," and it's
Yes.
like, yeah, but they have all these symptoms, and it's so
Hmm.
frustrating. So I think a lot of women will go in, with good intention and they're excited and then they go in and then they're just completely deflated because they're just dismissed or told, now you're too young. And then they leave in tears and they just go on for years, like you said, months or even years dealing with these symptoms because they're just not getting the help that they need. So I'm
Oh.
always, not only am I educating women, but I'm very much like, keep going. Like, let me put a fire, little fire under your butt to just
Yeah.
keep going. Don't give up. Don't just
Yeah.
like go to one or two doctors and give in. Like, keep going until you find somebody who you can trust and who is going to support you because they are out there. I know it's not that easy, but they are out there.
They are. They are. It's a great
Yeah.
point. Yeah.
Yeah. So in regards to kind of going back to estrogen hormone replacement therapy, a lot of providers will say that women only need estrogen,
Hmm.
especially if they don't have a uterus. So can
Yeah.
you speak to that? Because of course we're fans of progesterone and estrogen. Why do they say this, and what are the benefits of progesterone as well?
Yeah, I really think it goes back down to the fact that our mainstream medical docs were trained that progesterone's only job in the body was to control the growth of the uterine lining. And
Mm.
if you don't have a uterus anymore, you don't need it because you don't have a uterine lining. So there's nothing could be further from the truth. We know that progesterone has huge bone benefits. It works really truly in partnership with estrogen to build bones. And you think about these women who have had hysterectomies and they're only offered estrogen. They're missing this huge piece of their bone health, especially because a lot of these women were having hysterectomies when they were young. Sometimes it's
Mhm.
in their 30s, sometimes it's in their 40s. So now they're going to go this whole huge period of time without progesterone. A lot of them aren't even offered estrogen, but having both offered, and honestly, it should be like sitting in the surgery waiting room for you, like when you wake up
Mhm.
from your surgery.
Yeah.
But progesterone, I mean, bone benefits, brain benefits. I mean, we know it's being used for like post-traumatic, any kind of, or like post-stroke,
Mhm.
post-traumatic brain injury. We've seen
Wow.
studies on that. Lung health. I mean, because again, there's receptors everywhere, the skin, the digestive tract. So we're talking
Mhm.
again, the mood, so calming, sleep. There are so many benefits with progesterone. And I think too, because progesterone and estrogen are really a team. They're like BFFs. They
Mhm.
really should not be separated. They need to work together. Progesterone has, breast benefits. It's very protective of the breast cells. So,
Mhm.
I think that all of that gets lost and is just, we are so like, we see so many of these providers just sort of cherry picking one hormone being more important than the other. And they're just all so important. And we actually have 100 times more progesterone in the body
Yeah.
than estrogen anyway. So how can we say that we only need estrogen, but we need no progesterone? It's like the craziest thing,
Yeah.
but it's just never been seen as this important hormone. And I don't know why. Yeah.
Well, hopefully we're changing that.
Yes. We want to change that.
Right?
Absolutely.
I'm
Yeah.
trying, we're trying.
We are trying.
It is so
Yeah.
important. And just because we see women every day, you speak to women every day, I speak to women every day, and we know what they're struggling with.
Yeah.
And we know that you don't have to feel that way. We know that you can
Hmm.
feel better. And just because we're getting older doesn't mean that we have to struggle. And even if our parents did, our grandparents did, and I see it even with my mom, my grandmother, and their health. And it's
Yeah.
not great. It wasn't great. My grandmother's health was, she lived to be 90 something, but it wasn't a quality life, in my
Yeah.
opinion. My mom, same thing. She's in her 70s and she struggles in a lot of ways. And she's
Yeah.
like, I'm ready to go on hormones. Like she wants to go. But now it's like, of course, finding somebody for
Yeah.
her. My
Yeah.
doctor is out of state and that's just another situation. But we're trying to get her on something just,
Yes.
to have a little bit of a better quality of life for as long as we have her here.
Absolutely.
Yeah.
Absolutely.
Yeah.
Yeah.
We've been talking about estrogen, how wonderful it is, replacing it. There are women who are concerned about going on estrogen if they
Mhm.
had breast cancer, if they had a blood clot. So, are there any contraindications for taking estrogen?
Yeah, I mean, the form definitely makes a difference. We know
Mhm.
that oral, and again, this is kind of nuanced too, because most of the data we have on oral, where we say, hey, it can cause an increased risk for blood clots, is with the oral synthetic estrogen, like
Yes.
what's in the birth control pill or what was in Premarin. I don't know that we know. From what I've seen, it doesn't look like there is the same clotting risk that there is as with a bioidentical or body identical oral estrogen. The thing
Mhm.
is, I always kind of just throw this out there too, even if because if someone has a clotting risk,
Mhm.
we wouldn't put them on oral estrogen, even oral bioidentical. We would definitely recommend transdermal. And I always think
Okay.
in this day and age, in people, when we're talking about women who are going through perimenopause, menopause, they're probably 35 plus, 40s, 50s, and older. We're kind of clotty. We're clotty people. Our blood vessels aren't in the best shape. We tend to overclot. We produce more clotting factors if we have a virus, a vaccine, if we have cancer. I mean, there's a
Mhm.
lot of things that can increase clotting factors in the blood that we don't necessarily look for before we would put
Mhm.
someone on oral estrogen. So I tend to sit in the camp of, ideally transdermal
Yeah.
estrogen is best because of all those other reasons. Now, I have factor V Leiden, which is a
Mhm.
predisposition to clotting. So I would be on transdermal. But even if I wasn't, who knows, right? Because again, I'm 53. Who knows if there's something going on in my body where I tend to have these increased, maybe my blood vessels are changing or things are happening. So I think just kind of sitting in the seat of safety, transdermal estrogen is probably best for most women that are in their aging years.
Mhm.
For in terms of a clot, we typically say if it was a provoked blood clot, so we know why it happened. Let's say they were on the pill and they're like, well, I had a blood clot because I was on the pill. It's a benefits risk. I mean, for someone like that, we would absolutely say transdermal estrogen is fine.
Okay.
In any woman who's had a clot before, I think it always would, it would make sense to do more of a deep dive to say, hey, what is clotting risk right now? Or let's take a look at some of those clotting factors, maybe a little bit of cardiovascular additional testing of some kind, just to see, hey, how are those blood vessels looking? But in general, that should not be ultimately a reason for not giving women estrogen. When we look at the benefits and risks, right? Because the possibility is very, very low when we think about, okay, all the things it's going to do for the body, because it does help blood vessels generally, and it helps the brain, and it's
Mhm.
going to help the bones and the vagina and all the things. So breast cancer it's nuanced. And I think, again, this may change. I could see this changing. Estrogen used to be used before we had tamoxifen. Estrogen was
Mhm.
one of the treatments for breast cancer. Believe it or not, women don't believe me, but I'm like, there's a lot of research out there showing estrogen was actually used to treat breast cancer. So why, and it worked. So why would we use estrogen if estrogen were the cause of the breast cancer? I
Mhm.
think some of the nuances with estrogen and breast cancer are there's some research showing that like having the body take a little bit of a break from estrogen sometimes can be helpful, and then bringing
Okay.
estrogen back in afterward. So generally speaking, right now where things stand is we kind of say treat the breast cancer, whatever that treatment looks like. Even Dr. Blooming has, talked about, I know we had an interview with him. I know I've heard him say it elsewhere. The idea that people had to be on tamoxifen for 10 years, then it's dropped to 5 years. He's like, it could be 3 years, could be 1 year. It might not be anything because
Mhm.
45% of women don't even respond to tamoxifen. It doesn't
Wow.
help them. So, and there's a lot of nuance with that. So it's
Okay.
like treating that. We want to treat the tumor, of course. Women with breast cancer can use vaginal hormones, though. So if women are having
Mhm.
issues, when we're using vaginal estrogen, or you can use vaginal DHEA, vaginal testosterone, or on the vulva, it doesn't raise the levels beyond that of a person who's postmenopausal. So if you're using it, and if you're, especially if you're blocking estrogen, or someone has low estrogen, it does not raise the levels. Essentially, it doesn't get systemically in the body to those levels because it's low dose vaginal estrogen.
Mhm.
So even breast cancer patients currently can use vaginal hormones because a lot of them are suffering with symptoms and they're sort of being ignored.
Mhm.
After their treatment, typically it's this benefits risk discussion and saying, hey, but when we look at Avram Blooming's research, and he wrote an article called HRT After Breast Cancer, where there were
Mhm.
25 studies or 26 that he looked at, and there was no increased recurrence in women who were on hormones, and there
Wow.
was no increased risk of death. So why would we withhold these hormones that have all of these benefits in the body and don't cause breast cancer? Like they're just, to me, still, I don't understand the logic or the rationale for any kind of long-term withholding of estrogen from the body. Some doctors will use, I know like Lindsey Berkson is a big fan of like testosterone,
Mhm.
using even progesterone. If someone can't have estrogen, like there's other ways to look at it, but women should not miss out. And I think it's all about, again, having that benefits versus risk discussion on these hormones. Other reasons, I mean, like endometrial cancer, there's just
Mhm.
like little nuances like that. But again, it just depends on sort of where things are at. We don't want to we don't want to bucket someone and say, you had breast cancer and now forever you're a breast cancer
Right.
patient. Like that's not
Right.
fair. Same with endometrial cancer, same with all of the other things.
Mhm.
So I think we just sit down and say individually in that woman, and maybe we have to do a little bit of a deeper dive in terms of looking at more, maybe it's certain blood work we're getting done or other types of testing or imaging or whatever it might be to say, hey, is this person, how are they going to do? At the end of the day, again, these levels are a fraction of what they were when we were in our 20s and 30s, and we were doing fine then. So,
Yeah.
it seems crazy to be like, no, we're going to withhold these like minute doses of hormones that
Right.
have all these benefits
Right.
and very
No.
little risk when done
Exactly.
right. Yeah. Yeah.
Yes, when done
Yeah.
right.
When done
Yeah.
right.
Oh
Yeah.
my gosh.
Yeah.
I can talk to you for hours
I know.
and get on my soapbox about things.
Yeah. Yeah.
Because it does seem so foolish
Yeah.
that women are denied these hormones. And they're just being given false information. And again, it's being instilled all this fear.
Yeah.
And again, I think a lot of this is because a lot of physicians are living in fear and because they're not really doing the research. They're not digging into it for whatever reason, whether it's
Yeah.
just not in the curriculum, they don't have the time, they don't have the interest to dig deeper. But to instill fear in women to me is just so negligent and doing so much harm. And I
Yeah.
see it, but yet we don't think twice about giving women, like you said, all of these different medications that come with their own set of side effects.
Yeah. Yeah, absolutely. I know. And it's very litigious society. So I think physicians and
Hmm.
nurse practitioners are worried about getting sued,
Yes.
rightfully so. So it's like, And everybody wants to just point their finger at this thing. It's like, I mean, what breast cancer patient is told, let's look at nutrition. Let's look at, not that it's their fault, but I'm saying we're trying to optimize the body.
Yeah.
We shut down estrogen, but we don't say, hey, look at your personal care products that have estrogen in them. Look at the estrogen mimicking chemicals. Look at your pots and pans. Look at your plastics. I mean, you look at the hair coloring and all of the products we use in our body. We're not having that discussion. And that's what we're seeing. It's been so problematic in women's bodies that we're
Mhm.
blaming estrogen for something that is not estrogen's fault. And so women just end up suffering and they get put into this care vacuum and they never get out of it. So, yeah, I mean, I'm definitely beating the drum on that one too. I feel like it's so important that women get that attention that they need.
Yeah. Well,
Yeah.
thank you. Thank you for
Yeah.
all the work that you do. You are a wealth of
Yes.
knowledge. Like I said, I could talk to you for hours,
I
but I want to be
know.
mindful of your time. Hopefully, this episode has opened a lot of women's eyes and hopefully some providers who listen as well. There's a lot of unlearning to do.
Yeah. Yeah.
So having these
Absolutely.
conversations is really vital. So women not only feel empowered, but hopefully they can better advocate for themselves.
Yeah. That's what it's
Yeah.
all about. Yeah. Yeah. Thanks for
So,
having me.
of course, where can women find you and how can they work with you?
Yeah, so I don't see patients one-to-one anymore. I stopped about 3 years ago, but I have an online community called Pausing Together, which you know.
Mhm.
I have a guide called The Beginner's Guide to HRT, which is actually in process of being sort of redone. A new version will be coming out. I'm on Instagram. I do a lot of talks and things like that. So I do love if there's groups of women who, like want to talk or, want to sort of have like that hour to just talk through things. I do love to do talks with groups of women. So that's the place, and you can find me on my website, and that's listed there as well. Yeah.
Perfect. I love that
Good.
you speak to groups of women.
Yeah.
It's so needed.
Yeah.
I will link to all that in the show notes, and we will be sharing you, of course, on Instagram. Thank you again so much for being here, and until next time.
Yes. Thanks so much. It was so much fun. Thanks, Claudia.
Great. Bye.
Bye.
Hey, before you go, if you're ready to get educated, empowered, and feel your best in your peri years and beyond, grab my must-have guide for women 40 plus navigating hormone changes via the link in the show notes. You'll learn my top 5 strategic diet and lifestyle changes to make ASAP to support your declining hormones and get back your energy, improve your mood, and confidence. The information provided is for educational and informational purposes only. I am not, nor do I act as a doctor or any other medical professional. I am not providing healthcare, medical services, or attempting to diagnose, treat, prevent, or cure any physical, mental, or emotional disease or condition. The information shared is not intended to be a substitute for the professional medical advice provided by your own medical or mental health provider.